if you pop a hole right here in your neck and put a tube in there directly into your lungs, all your problems with snoring go away immediately, and you have a whole new set of problems, like drowning when you take a shower and not being able to talk to your wife.
Exactly. Hello, everybody, and welcome to this episode of Vital Discourse. We've talked a lot about sleep apnea. We've had multiple episodes, Dr. Ben and I, talking about sleep apnea. We haven't really done one that just talks about the treatments for obstructive sleep apnea. So that's what we're going to hit on today. And I'm going to look to Dr. Ben to first kind of give us the categories of the different types of treatments. I will give as a caveat to this, we're assuming in these situations that the nasal airway has been dealt with, that we have an excellent nasal airway, because without an excellent nasal airway, none of these other treatments really work as effectively or as efficiently. We described in one of the previous episodes, it's kind of like a pipe that has 3 narrow areas and the water's going through the pipe. If you fix 2 of the narrow areas, still the same amount of water is coming out through the other side of the pipe. You got to fix all 3 areas. So I'll turn it over to Dr. Ben to kind of give us the categories and the different types of treatments that we can utilize for obstructive sleep apnea below the level of the nose.
Thanks, Lee. So basically, at the level, it's a 3-level problem: nose, palate, and tongue. At the level of the palate and tongue, so you've already fixed the nose, the nasal airway's been evaluated, you got it open. You're looking at, well, what do I do now? How do I treat the palate and tongue? Because it's floppy and it's collapsing back. It all comes down to the category that you've been put in with your sleep apnea. So you're going to have a sleep study, and your doctor's going to tell you you're mild, moderate, or severe. The category, in general, the 4 categories of treatment for the palate and tongue are some type of mask pushing air through your nose and pushing your palate and tongue forward, the CPAP mask, the BiPAP, the APAP. The stimulator devices, there are 2 of them that are FDA approved in the US now, the Genio and the Inspire implant, that stimulate the palate and tongue and pull them forward, lift them out of the way, and open the airway at night when you're sleeping. And then some type of mouth appliance, that a mandibular advancement device that pulls the tongue forward by moving the mandible forward. And of course, the tongue's attached to the mandible. That's how it opens the throat. And then surgery, the broad category of surgery, where you're trimming the palate, moving the tongue forward surgically through a little incision under here, or moving the entire midface and mandible forward. OMFS surgeons advocate that quite often. So those are the 4 basic types of things that we do. In general, as you get worse, your options get fewer, right? So it's quite possible that if you're very severe, that your only 2 viable options are the combination of the MMA and stimulation versus mask. So you become a little bit more unidimensional as you get worse.
So let's first talk about the thing that everyone hears about and that most people are told to use, even if they have really mild sleep apnea on a sleep study, because most sleep apnea is first seen by either a primary care physician or a pulmonologist. And even if it's just a little bit of sleep apnea, something that you or I might not treat with something like CPAP, because we know that there are other ways that it can be treated. People are told you need to wear a CPAP machine. So we always hear CPAP is the gold standard. Is it?
So that's a great question. I mean, if 50 to 80% of people fail CPAP in the first year, how can it be the gold standard? Well, let's unpack that a little bit. So the Iwata study, right? So the Iwata study showed that most people that fail the CPAP mask are failing it because nobody checked their nose and they have a nasal obstruction. And then when you fix that nasal obstruction, 100% of those people, actually no, 40, I believe it was 47 of the 50 were able to then wear a CPAP mask, and 3 of them were actually cured of their sleep apnea. So it's a little bit misleading when people don't do well in it. So how can it be a gold standard? Well, if you properly assess the nasal airway, remember that these people can wear the CPAP mask. It does work, and it's cheap and easy to use. So if it's cheap, easy to use, and effective, that qualifies as a gold standard. Again, the caveat is that a lot of people fail it, but they fail it for reasons that are preventable. So make sure that you're looking that you're talking to docs as a team. You're not just going to one sleep doctor who tests you, you're positive for sleep apnea, slaps a mask on you, and you're out the door. Typically, you want somebody to evaluate. Certainly, if you come back and say, when I put my mask on, I feel like it's suffocating me, and you want to try and be seen by a doctor that's going to help you tease that apart. That's not the way CPAP should feel. You might be one of those people with a nasal obstruction. So yeah, it's a gold standard. I mean, you can say that it is. It's got an asterisk though, right? It's not like all these treatments. They're treatments with an asterisk. The asterisk for CPAP is that.
That's assuming that the CPAP machine isn't leaching carcinogenic materials into your airway.
Right. Yeah. So, I mean, yeah, obviously, one of the companies that made sleep apnea machines, it was found that it was actually causing a cancer in people's lungs because of the deterioration of the materials it was using. They're fortunately off the market now, but yeah.
So we hit CPAP. What's next up?
Well, the stimulators. So look, stimulators are all the rage. By the way, I'm maybe a little bit biased. I was the first one to implant a stimulator in the state of Texas successfully, and I've done probably more than anybody here. It's stimulators, I think, are the future of this. Look, you have the definition of sleep apnea, again, is a progressive weakening of the structures of the back of the throat mixed with a nasal obstruction over time. Progressive weakening over time in humans is kind of analogous to aging. It's aging, right? So it's how we age. It gets worse with time. There are some other factors like obesity and some lifestyle issues, but in general, you're getting worse over time. And so if you get floppy and fall back and block your throat, it makes sense that you add stimulation back. When are you getting floppy? You're getting floppy during the day? No. You're getting floppy when you try to go through deep wave sleep, slow wave sleep at night. Your REM stages, the restorative part of your sleep cycle, requires that you get relaxed. And when you do, when a sleep apneic does, the palate and tongue fall back, block the throat, and cause obstruction and cause your oxygen to drop. Well, stimulators like Genio, the new one that goes under the chin, and Inspire, which has 2 incisions. We should talk about these two because they provide stimulation precisely at that time in your sleep cycle when you're collapsing and disrupting your sleep. So in my opinion, it is precisely undoing what the problem behind sleep apnea is, and that is obstruction at the time of restorative sleep.
Now, I want everyone to understand that not all surgeons that use these implants, that insert these implants, are created equal. Okay? So it is very, very surgeon dependent. You have to tease out which branches of the nerve you're going to actually stimulate.
Well, that's for one, right? So that's for Inspire.
For Inspire.
Yeah, so for Genio, it's a little bit different. And I should also say Genio has just been FDA approved, I think 2 months or 3 months ago. And so only 800 or so have been done worldwide. I have never done one. I've done cadaver lab dissections on them. So I've done thousands of surgeries like you have in this area because we're both head and neck surgeon trained. But I haven't actually put one in. You don't have to tease apart. Actually, we should talk about the differences between Genio and Inspire real quickly.
Yeah, and I have done Genio.
You have. That's right. You were one of the first guys. You're one of the first 800.
Right. So Genio is much more of a non-specific stimulation, so it doesn't get down to the specific nerve branches, and it
Well, it kind of does though, right? Because it's after the separation. You're getting it midline. The big thing with Genio is it's bilateral.
right, and that's what I was going to say. The difference, how it makes up for it, is because it's bilateral.
But the branches have already separated. Once it comes into the midline, the exclusion branches separate themselves out and go superior,
Right,
right? And so you just lay it across this already anatomically separate branch. You lay them across it.
which is easier said than done
Easier said than done. Yeah.
because it's just a paddle that sits on it. You're not actually wrapping a cuff.
Now, when you did it, you used the older one that was larger. The newer one is very small, and the paddles sit a little bit better. We probably there's another doc in town that's done a few of them already. I haven't done any yet. So I was the first Inspire. He's the first Genio now, but he's only done a few. So what's the difference between the difference between Genio is bilateral.
For people that don't understand medical terminology, that means both sides, bilateral.
Both sides, yeah. And it's done through a single incision with no chest incision because the battery is separate. So you do have to wear a sticky device that holds the battery, and the battery communicates through the skin and provides power externally to the internal device.
And the good part about that, just to interject, is that with the Inspire, for example, you are actually inserting the battery, okay?
So the battery sits in a separate incision for now, a separate incision down on the chest.
And that battery has a life to it, has a finite life to it. And when that finite life is up, you have to replace it.
We think it's somewhere around 12 years. Yeah, we think it's and by the way, when you replace it, I've replaced one before. It literally takes about 15 minutes. It's a very small local procedure. You just make a little stab incision, you pop it out, pop a new one in. So it's pretty simple to do the replacement. And I have a lot of history with Inspire. I think it's a great company. I think they're doing incredible the research and advancements on their product, which I commend them for. Every iteration is getting better and better. The 5 that's out now is smaller, smarter. It no longer needs a sensor for the lung. It works on an accelerometer. An accelerometer is inside that battery pack that times it. Genio is not timed with your breathing. Genio just has a it has a pretty good correlation, but only about 85%, whereas Inspire is precisely timed with your breathing through this little device, this accelerometer that can sense your breathing. So the sensors inside Inspire are extremely advanced, and so its success rate in my hands is about 94 to 96%. Nationwide, it's 79%. That's what's quoted on the Adhere study. What is it doing? It's stimulating. There's 56 branches of this nerve in your neck called the hypoglossal nerve. I tease out the anterior 18 branches and put a cuff around it.
Anterior means the ones towards the front.
Yeah, so there's a subset of ones, and what do? They pull your tongue forward, right? They raise it up in the mouth and they stiffen the tongue. So they basically open the back of the throat. But if you're looking down from the nose from above, it actually opens and works on the palate as well. So that you'll see the palate and the tongue and everything, the whole airway expand open. And it does it in a very profound way. But in general, the opening to the airway is profound during an awake endoscopy. And it's timed with your breathing. So when you inspire, that's where they get the name. When you inspire, the airway is unfettered. Again, you need a good nasal airway or it won't work.
Let me ask you 2 situations, okay?
Yeah.
So the first thing is, well, actually, I have 2 questions. The first question is, well, why don't you just stimulate it all the time? Why are you only stimulating it when you're inspiring or when you're breathing in? That's the first question. The second question is, what if the cuff doesn't go around the anterior or forward branches of the nerve, and it's put on some of the branches that are more posterior towards the back. And that kind of ties into, you really need an experienced surgeon that knows what they're doing with Inspire.
Yeah, well, the whole team actually, because the Inspire folks are in the room with you. They're fantastic at monitoring what you're doing in the surgery while you're doing it. I've had aberrant branches that get locked into the cuff, and even though I'm testing it, I can't see that branch. But then when you turn it on, I test the entire thing before I close it. When you turn it on, instead of poking out, it'll poke out and curl or retract. So when those retractors get laid in at lower power settings, and we tested at high, mid, and low settings. At the low settings, it'll deliver a little bit of energy to that aberrant branch, and the tongue will jump back.
So what Dr. Ben is saying here is that if it's put around the wrong branch, you can tell at the time of surgery, and you can manipulate the cuff, because when you're stimulating it, you can actually see the tongue push back instead of push forward the way it's supposed to. So it's kind of a built-in safety mechanism while you're putting the implant in.
Yeah, and early on, that happened to me, and I had to go back in, find out what branch it was, roll the nerve over, and actually tease it out and push it out of the way. So we don't stop until we get a really good test. The first question, though, is pretty profound. Why don't you just stimulate it all the time? Well, because it's a muscle, and anybody that's worked out or lifted anything or tried to do any sort of physical exercise knows that you get fatigued. That muscle will get fatigued, and it won't respond anymore, right? I mean, there's a certain way that muscles get stimulated, and it's not all the time. You get diminishing returns.
That's what makes Inspire so unique, and the people that created it so incredibly brilliant in terms of, kind of figuring that out. How do we get around the fatigue of the muscle? And they figured it out.
One of the other things is that the people at Inspire really understand what's going to take us to the next portion, is that it's got to be a team approach. And so in my team, I'm a center of excellence for Inspire. And part of that process was, there are a lot of criteria that they use. But part of that process was ensuring that I have a viable team to make sure that we do the right thing for the patient. So I may not be the best at everything. I have 3 dentists that work with me pretty regularly. I have 2 neurologists that are sleep board certified that work with it. Because, there are not all problems are obstructive sleep apnea. People have multiple sleep problems who come in. Some of them have insomnia that needs to be teased apart and treated before you do this. Some of them have narcolepsy. Some of them have, different types of central sleep apnea and things. All this needs to be dealt with, and Inspire makes sure that you are looking at the entire patient, which is very rare for a company. So there are a subset of people that wind up just getting a mouth guard. I fix their nose, and they want to go the level of the mouth guard. And for moderate sleep apnea, that's a very viable thing to do. So you should probably talk a little bit about mandibular advancements devices, Lee, MADs.
Yeah. So I'll go into a couple of different areas with this. The first is that a mandibular advancement device is basically a mouthpiece that's put in your mouth that goes on the upper teeth and the lower teeth. And there's usually a little kind of ratchet on it. And that ratchet allows you to determine how far forward the lower jaw goes and how open the lower jaw goes. So when you see these different mandibular appliances or sleep apnea mouthpieces that are advertised over the counter, where you can just purchase it online, or you can purchase it at a store, and you throw it in some boiling water and put it on your teeth, and it's supposed to mold to your teeth, and then it's supposed to cure your snoring or sleep apnea. Most of the time, in my experience, they don't work. And they don't work for several reasons. Number one, even though it's boil and bite and it should fit your dentition properly, usually it doesn't fit your dentition as well as if it's made by a dentist, and specifically a dentist that does sleep dentistry. So that's number one. Number two, these devices do various different things. One of them sucks the tongue forward. Sucking the tongue forward doesn't do anything if you don't have room for the tongue to go. Okay, that's the problem. Is the tongue usually is overly large for the space that it's in, and it's falling back. If you try and suck it forward, it does absolutely nothing. The second thing is all it does is ratchet forward. Okay, so if all you do is ratchet forward the lower jaw, the tongue is coming forward with it, but it's just hitting the front teeth, and then it's cantering backwards. Okay, so it's really doing nothing for you just to go forward. You have to go forward, and you have to have some mouth opening as well. With that mouth opening, as you ratchet forward, the tongue actually has space to fall into. And I even find many dentists don't understand this completely. You, the sleep dentist that I refer to, they do a great job at using diagnostic tools to determine exactly how the airway is expanding when they're using the oral appliance, and that makes a huge difference in terms of the effect.
I mean, they're just like us, though, Lee. I mean, there are ENTs that don't understand sleep. I'm sure that there are dentists that don't understand sleep because that's not what they do. But they might want to get into the game because you can sell these appliances. But if they're not really dedicating their lives and their knowledge and their learning to sleep, they might have some deficits in their knowledge.
So I would say from that perspective, the vital discourse, idea of the day here, if I was going to put one out, at least as it pertains to this, is that if you are thinking about or someone has recommended an oral appliance, go to a dentist that does sleep, specializes in sleep dentistry to have your oral appliance made. You'll have the greatest chance that oral appliance will actually have the effect that you want it to have. Now, the other thing as it relates to oral appliance is that the tongue is coming forward, okay? And the tongue is coming forward to create space behind the tongue. But if there's something else filling that space, we have a problem because the tongue has to come that much farther forward in order to have the same effect. And we're talking about the palate. So if the palate is overly long or overly floppy, the tongue needs to come farther forward in order to create the same amount of space. So I do a fair amount of palatal surgery on patients that I'm going to recommend an oral appliance for. And what that is to get the palate higher and tighter so that the oral appliance doesn't have to do so much work pulling that tongue forward. And it really increases the efficiency of the oral appliance greatly.
You see what you just did? You just segued us from oral appliances into surgery.
And that was my idea.
The segue, the Lee segue. So talk to us. So what's you do a little bit different palatal surgery than some docs. So tell me about what you're doing. Palate is the little punching bag at the back of the throat. It's the thing that's making a lot of the noise. The tongue and the palate make up their own different types of noises. What are you doing for the palate, and why does it work?
So if someone opens their mouth and they look in the back of their throat, they'll see an arch on one side, and then it comes down. You have, like Dr. Ben was saying, that little punching bag, and then an arch going back up. Okay, so that whole soft area before you get to the hard palate, which is the hard part that you press on the top of the roof of your mouth, all that soft part is considered the soft palate, and the soft palate is what we're talking about.
What does it do? Why do you have it? Why don't you just cut the whole thing out?
So it separates the nasal airway from the oral airway. So it basically separates the nose from the throat. So interestingly enough, and I get this all the time, if you're going to shorten my uvula, that's the little dangly thing, the punching bag. If you're going to shorten my uvula, well, isn't it there for a reason? Yes, it was there for a reason that you don't need anymore. Okay, so in the first year of life, we're what's called obligate nasal breathers, which means we must breathe through our nose. We can't breathe through our mouth in the first year of life. And what happens is the palate is what separates our nasal airway, or I should say our airway, from our swallowing tube. So you can see a baby drinking a bottle, sitting there for 20 minutes drinking a bottle without coming up for air. Well, we couldn't do that, right? With each swallow, we stop breathing. Baby doesn't do that. Baby can actually breathe and feed at the same time. And it's a function that is protective so the baby doesn't choke, right? So after the first year of life, we're not obligate nasal breathers anymore. And so it's what's called a vestigial organ, kind of like the appendix. You don't need it after that first year of life, okay? And many times it becomes bothersome.
Well, you don't need the uvula, but you do need the soft
You need the
palate
soft
in order
palate. I'm
to
talking about
swallow, make a seal, speak. Everybody knows that kid who has no palate or has a split in it, gets a lot of nasal air escapes, can't speak properly. So it's pretty important. And by the way, if you take too much of it, you develop problems like that. Too much nasal air escape, difficulty swallowing. When you swallow, fluid, milk comes out your nose. So what are you doing when you take it out? Why are you different than everybody else?
So the classic procedure to treat the palate is to make a big incision across the entire palate and remove the lower part of the palate along with the uvula and sew it up, okay? That's the basic procedure that most general ENTs do. You're hard pressed to find a sleep surgeon that would do that procedure anymore, but a lot of general ENTs are still doing that procedure. What's the problem? The problem is if you take too much, you get what Dr. Ben was just talking about, velopharyngeal insufficiency. You're not now able to close off the nasal airway from the oral airway. If you try and say, for example, a consonant like a K, instead of saying kitty cat, it'll sound like this. You won't be able to make that K sound, okay? And when you drink something, it'll go up into the back of your nose instead of going down into your throat. Really not a good complication to have, okay? So that's the first issue with that procedure. The second issue with that procedure is the scarring from that procedure. So when you make one big incision, okay, that incision as it closes will generally scar down. It will close down on you. And when it closes down on you, it could actually have the opposite effect of what you wanted. It could actually close down your airway, make your airway smaller instead of larger. So that's the biggest issue. Now, people have come up with all types of different surgeries. I've done most of them, taking muscles and reorienting them, expansion sphincter pharyngoplasties, Z palatoplasties, all these different types of procedures to try and overcome that. I don't find that any of them are great procedures by any stretch of the imagination, but what I've developed is something I call minimally invasive palatal stiffening. And what I do is I do a limited resection or removal of the uvula, of the punching bag. And then through the opening, I pass a laser fiber. And I pass that laser fiber into the deep tissue of the palate, and I heat the deep tissue of the palate, and I heat the inside, basically, of the uvula. And over time, that scars. And as that scars, it pulls the palate up, pulls the uvula up, but it keeps the mass of the palate. So the palate stiffens and it pulls up. But because you're not cutting out palate, there's literally no risk for velopharyngeal insufficiency, and you get a great minimally invasive procedure that accomplishes what we want to accomplish, okay?
Are there surgeries for the tongue that you like over others that can pull it forward, shrink it, do things that can help?
The only thing that I think really has been shown to work for the tongue is a mandibular advancement. I mean, realistically speaking. So that's the oral maxillofacial surgeons do that. They actually break the jaw, pull it forward, and plate it forward.
So you don't do hyoid suspensions?
I've done them. I never really found them to do that much. In a very limited, if you look down,
if I do UPPP with and pull it forward like the airlift procedure, if the mass is not too large, if they're Malampati 2 or 3, but when you scope them, their tongue's sitting back pretty far. I get really good results for moderate sleep apnea. I know that's a lot of qualifications, but never for severe. It doesn't really work for severe. But for moderate sleep apnea with a low Malampati score and it's the tongue base is sitting back against the back wall of your throat, I get a pretty good result with it. But again, so many qualifications, and by pretty good, maybe 70% cure.
For me, when I do my flexible scope, so we'll take a flexible scope, we'll go through the nose and we'll look down at the airway. we'll be able to see the tongue. We'll be able to see the epiglottis, which is a little flap that closes over your airway when you swallow. When I see, for example, epiglottic inversion or an omega-shaped epiglottis, those types of things, or the tongue actually pushing back on the epiglottis, that's more when I end up using hyoid suspension.
So you mentioned the MMA. You mentioned a mandibular advancement, maxillary and mandibular advancement. So yeah, you heard that right. There are people out there. The OMFS is usually, although I've done this surgery because where I trained at University of Washington, where you actually cut these bones here, and you pull them all forward, and it pulls the palate forward, it pulls the tongue forward, everything, and it's effective. It's very effective. What's up with it? Why isn't everybody doing it?
That is a big surgery. It takes a long time to recover from it. There's a huge amount of blood loss, especially in the mandibular surgery. In my community, there's some people that have done it, and there have been some really negative outcomes because it is such a big surgery, and it changes the way you look.
We do have some good OMFSs here in Houston that have a good track record with it. I can tell you that my PA has had it done for other reasons when he was young. He had a birth, not really a defect, but he had an anomaly and had to have it done. And it changes the look of your face, as you can imagine. He had mid-face protrusion, and he had the whole thing brought forward. Causes severe problems with swallowing afterwards. Your jaws are wired shut. His were wired shut for 6 weeks. He lost, massive amounts of weight. So it still has a place here, and if it's done well, just like anything, if you have the right surgeon, it can be a dramatic change in the airway. But again, quite a surgery to go through.
So should we add as a potential treatment tracheotomy?
Hey, so no, it's good to mention. Listen, look, if you pop a hole right here in your neck and put a tube in there directly into your lungs, all your problems with snoring go away immediately, and you have a whole new set of problems, like drowning when you take a shower and not being able to talk to your wife.
Exactly.
So that's right. This whole big piece of meat here, is the problem with snoring, but it happens to be who we are, right? It's your face and your throat and speaking. And so, yeah, you can immediately fix it by doing a tracheostomy. Ostomy means making a new mouth into your airway, into your trachea, and taking this big piece of flesh that we call the head out of the circuit. That's a good point.
Yeah. So, and if people are confused, they've heard tracheotomy versus tracheostomy. A technical difference in medicine. Otomy is something that's considered not permanent. Ostomy is considered something that is permanent. So that's the only difference.
Making a new mouth, making a new os.
Exactly.
We still rely on Greek and Latin, even in today's day and age.
Every specialty, whether it's a medical specialty or any other type of special service out there, has their own set of terminology, mostly so that no one else can understand what they're saying.
Yeah, it's jargon, man. I mean, everybody has jargon, and when anyone who's built a house will realize immediately that they don't understand anything the contractor's talking to his men about, and so it's not about intelligence or anything. It's literally just learning the jargon. I mean, you're a lawyer, for God's sakes. You just passed your bar, and when you're talking about a lot of your stuff, I have to stop you and be like, I don't know what the hell you're talking about. So myofunctional therapy, we got to talk about it. We didn't list it as one of the 4 categories. Why? Because it's not a cure.
Well,
but it does help.
It helps when it's done right, and it helps when they're concentrating on the right areas.
So tell us what it is. What's myofunctional therapy? What are we talking about?
It's basically muscle training, right? It's training the muscles so that the tongue protruders, the muscles that push your tongue out, are becoming quote unquote stronger than the muscles that are pulling your tongue backwards. So just like when you're working out, I'm trying to, if you build up your biceps and you don't build up your triceps, instead of your arms being straight, your arm's going to be like this all the time, right? So that's basically what it is. I can't say that I have a whole lot of patients that have undergone. Look at that big boy. I those guns. I can't. I can't say that I have a whole lot of patients that have gone through it that have said that it's really done a whole lot for them.
There's a lot of influencers out there, though, showing you to kind of go, and you're going to fix sleep apnea. You're not going to fix it, okay? It's wonderful to do. I think, Lee, you hit it right on the head. It's a great adjunct. I actually chew natural gum to try to strengthen the muscles of my throat because I have severe sleep apnea. I just do everything that I can. I try to keep my weight down. I do all these ancillary things so that the ways that I fix my sleep apnea work for me. But yeah, it's important to understand that you can't fix apnea with exercises alone. A lot of influencers tell you the opposite.
100%. So the next thing, and I don't know if we listed it or not, is medications. Can you tell us about that?
So what are the main medications for sleep apnea? So there are things that you can do because what's the main symptom? The symptom is sleepiness, right? And so if you're sleepy, you want to try to reverse that. So what are the main medications just for reversing the sleepiness? And a lot of people ask you for scripts for it. What are you getting asked for scripts for to reverse the sleepiness?
Well, the script that I'm asked for the most are the GLP-1 medications to lose weight.
Well, that's weight loss, though, right?
From a medication perspective, and really we need to talk a little bit about that as well, because that is an adjunctive treatment. And in some people, it is even though long-term it might not be curative, in many patients, at least in the short term, it can be curative.
Well, there is a graded reduction in AHI, the number of times that you stop breathing, with percent body weight losses, but it doesn't cure it by itself, and it doesn't stop its progression. So there's always a caveat. For me, weight loss is always a part of my treatment. We should have probably said that to begin with, along with the nose. We should have probably talked about how weight loss affects sleep apnea, and is it part of our treatment? So I fix the nose on everybody that needs it fixed, and I talk about. So remember, only 40% of people, this is another episode that we had, only 40% of people are obese who have sleep apnea. So it's not everybody. So if somebody's overweight, I immediately talk to them about weight loss, and I make GLP-1s available to them. Zepbound, tirzepatide, I think, is far superior to semaglutide. But again, as long as you're working with somebody in a comprehensive diet and exercise program, I think it's great. What about medications though for mentation?
Well, so let me just go back for a second on what you were saying. So part of the issue with treating obesity not necessarily being curative is in the same way that if someone is obese for an extended period of time and loses weight using one of the GLP-1s, what do they end up happening? They have all this excess skin, right? So the throat's no different. If you expand the tissues of the throat and then all of a sudden decrease the fat that's interlaced in the muscle now when you lose weight, you're going to have redundancy of that tissue. You're going to have extra tissue that is going to be collapsible. And so to Dr. Ben's point, you might significantly improve the sleep apnea from an AHI perspective on a sleep study, but it doesn't change the progression over time of the sleep apnea, and you still quote unquote have sleep apnea. From a medication perspective, there's an investigational drug called AD109, right? So that's a combination drug. The clinical trials have been positive, right?
But they're not touting it as a cure. Again,
These are neuromodulating agents.
what does that mean?
So what's happening when we're sleeping at night is during REM sleep, which is rapid eye movement sleep, that's when we have our dreams, right? So our body's very good at protecting us. And one of the ways it protects us is it doesn't let us act out our dreams. The way it doesn't do that is it makes sure all of our muscles relax. So our muscles aren't really necessarily functional, so to speak, when we're sleeping in REM sleep. And what happens when our muscles relax? They tend to collapse. So a neuromodulating agent will increase the tone of those muscles so they don't collapse so much when we're sleeping at night.
Guess what else it does, though? Keeps you up. So
Yeah,
what's the side effects of it?
It's a stimulant, right?
Yeah, it's a stimulator.
Exactly.
So it's hard to go to sleep. It's got a lot of limitations. It can actually create some insomnia, some delay in trying to get to sleep, or you can start waking up throughout the night as well if you weren't before.
Yeah.
And also constipation.
Hate having constipation.
Yeah, that's something to
We
stay
could
up
do we
at
could do
night
a
for.
whole episode on constipation.
Oh, gut health. Are you kidding? Gut health is where it's at now, right? Everything's
absolutely.
the biome, the gut biome.
Oh my goodness.
Well, actually, right? I mean, the gut, looking at functional medicine, we're going to talk about the gut controls your mood. I mean, it controls a lot of the chemicals in our brain that are mood related. And so the gut is very important in sleep as well. So we're gonna talk about gut health in the future because there's so much coming out about it. Some of it's crazy, some of it's not.
To your point, there are supplements out there specifically targeting the gut-brain axis, right?
Yeah,
And
absolutely.
and they've been shown to actually have really some very positive effects, ashwagandha and things of that nature.
Yep. So, but with that said, let's bust some of the myths though that are out there with curing sleep apnea online. How does mouth tape work? Does mouth tape cure sleep apnea?
Mouth tape in no way cures sleep apnea.
When do you use it? I mean, when can it be used? There are people out there touting it, saying that it has clinical evidence that it fixes snoring and sleep apnea.
There's no clinical evidence in any type of that I'm aware of in any type of placebo-controlled trial.
Not at all. It's usually mentioned because once you fix a nasal, first of all, if my nose is completely blocked and I tape my mouth shut, how long will I live?
4 minutes?
Well, no. So there's that one guy that just broke the record and stayed underwater for 29 minutes. I don't know how the hell that happened, but in general, yeah, about 4 minutes and then you're dead. So if you fix your nose and you can breathe through your nose well, but you're trying to use one of these treatments and your mouth keeps dropping open, especially with masks, with CPAP, a lot of times they recommend taping your mouth shut. Now, training yourself to breathe through your nose in a nose that works, it's also been shown to help in that regard as well, is to put a little bit of tape over there. In George Catlin's book, The Breath of Life, the Native American moms used to watch their children sleep and train them to breathe through their nose by pinching their lips shut, and that's where the idea for mouth tape came from. It does not cure or treat sleep apnea. Just be careful that you don't put it on if you have a nasal obstruction.
Yeah. So one of the things, if you put it on when you have a nasal obstruction, although they tout that in an emergency it will open, there's a little perforation there, and it can open if you try and open your mouth.
Some of the good ones have that. A lot of them don't.
Right. And so, but the issue is you're asleep. Okay. So
yeah, how are you going to know?
Who knows what the body's going to do at that point? And all it takes is a few attempts at inspiration, at sucking in air against a closed airway to cause something like negative pressure pulmonary edema. So what happens is you're sucking in, but you're not getting any airflow because your nose is obstructed, and now your mouth is taped shut. And that negative pressure in the lungs actually pulls water into the lungs.
Yeah. Dangerous situation.
Yeah.
Also, if your oxygen goes too low at night, you can just go into an arrhythmia and die. So it's not a good thing to do if you have a nasal obstruction.
Generally considered bad form.
So myths that we've kind of busted tonight. If I just lose weight, I'm going to fix my sleep apnea. Not really. It's a great adjunct. It's not seen as a cure by itself. Poking your tongue into the side of your cheeks. Myofunctional therapy, again, not great, not a cure. Mouth tape, not a cure. The online mouth guards, not typically seen as a long-term solution. But the great cure, the four categories that we were talking about that do cure the palate and tongue portion of sleep apnea after you've opened the nose. CPAP mask, real easy to use as long as your nose works. Very easy, cheap, and effective. Stimulator therapy. I happen to think the stimulators are the future of sleep apnea treatment. They're going to get better. They're going to get smaller. They're going to get much more accurate. Right now, they're Inspire and Genio. Lots of companies coming into that space. There are a lot of great technology coming out. Surgical interventions by OMFS doctors, by ENT doctors, head and neck surgeons to trim the palate, tongue, and move the bones forward. And then the mandibular advancement devices, the devices that pull the jaw forward. Those are the four sort of vetted ways that we treat this. What else, Lee? What am I forgetting?
I think you rounded it out beautifully. So everyone, thank you so much for listening in, watching if you're watching, and this ends this episode of Vital Discourse. Can't wait to see you next time.